Welcome, everybody, back to Diversion Insights. My guests today are from a hospital in the DC metro area. We have Jen Raynor, the Director of Pharmacy, Jeri Yeman, the Quality, Safety, and Regulatory Compliance Manager and Medication Safety Officer, and Jason Ramos, the Regulatory Compliance Coordinator. I want to welcome all of you. I am really looking forward to today's conversation and showcasing to the listeners the things that you are doing within your pharmacy and your facility. My team performed a diversion risk assessment at this facility, and while there are always findings and room for improvement, this team has so many great things in place that I really thought it would be of value for the listeners to hear about it. So let's get started. Jen, I'm going to start with you. Can you give us an overview of the journey? You have built a program over time. It took a vision and support from your leadership. So tell us about that journey.
Jeri, thanks. Good to see you again. Thanks for having us. Yes, when I assumed this role about 15 years ago, we were at the beginning of our journey. And so, we were really focusing and we were really operating as a local community pharmacy. And as the years went on, we did have a lot of restructuring. We had a lot of input from the health system around strategic initiatives, et cetera. Again, when I first arrived here, we had a part-time medication safety officer, and she was a very seasoned nurse. And when she retired, we took that opportunity to look at how we could absorb that work and bring it back into the pharmacy under the pharmacist's purview. At the time, Jeri was a clinical pharmacist. She did have a very keen eye in terms of medication safety. She had her residency here completed and stayed on with us as a pharmacist. And so I did approach her, asked her if she was interested in a role like this. She was very excited. And so we built this program back within the pharmacy under pharmacist purview back in around 2015. And so since then, as you know, regulations increase. Pharmacy world has changed very much in the last 10 years. And so as we work a little bit more in the health system, as the needs from a regulatory and a quality and a safety perspective increase and bear down at a very, very fast rate for all of us in healthcare, Jeri and I sat down and realized that the workload was pretty intense. And as my responsibilities grew, I realized that I couldn't support her as much as I could. And we had that discussion around what would this look like in a perfect world? What kind of skill sets would we need from a frontline perspective to help support all the work that we have going on? And so we sat down and first and foremost, we very, very much value here the work and skill sets of technicians. And so one of the first things that we did was try to understand what are the roles and responsibilities of a medication safety officer or a manager role that really could be done by a very seasoned and high functioning technician. And so we started there. We expanded some roles around regulatory compliance, around auditing, around things that technicians have a very keen eye for as well. And we started to enlist and understand the skill sets of our existing technician staff to see from an interest level if there was anyone who would be interested in joining Jeri either on a part-time or a full-time basis to help support the work she was doing. And so we do have two technicians, one of them represented here, and you'll hear from him, Jason. And at the same time, we realized that we needed another pharmacist within this division, our quality, safety, and regulatory division, to help with a lot of the auditing. And so, a lot of these audits that we do are through Joint Commission, they're through the Board of Pharmacy. And again, just from a bandwidth perspective, Jeri's role emerging into something that is much more health system focused. And so having a local pharmacist to be that liaison, to have that pharmacist clinical eye around a lot of the drug diversion mitigation audits that we do helped round out the team. And so here we are in 2025. We have 4 people in the division with Jeri as the manager. So we have 2 pharmacists and 2 technicians in our quality, safety, and regulatory division, and they do an excellent job. We actually just had an unannounced visit this week from the Board of Pharmacy, and we were 100% compliant. And so they keep us ever ready, always educating staff. And so there's just so many things I'm excited for my team to highlight today around what we do from a behavior perspective, from an auditing perspective, from a culture perspective, to support the hospitals, to support our safe patient care with drug diversion mitigation, of course, top of mind.
That's great. And I think it's great that you looked within your staff and recognized their skill sets and their traits and built upon that. That is fabulous. But I do have another question. How did you get leadership to buy into all of this, right? I mean, I think a lot of places recognize they may not know exactly what they want or who is going to fill what spot, but they know they need more help to really do a good job. So how did you get them to give you these 4 people?
So it was a long process. Definitely didn't happen overnight. At the time when we discussed the theoretical idea of this type of division, I had 5 years here and had a good rapport with executive leadership. And so, just from, I guess, our own reputation, our own way of how we've increased customer service, how, well respected we were within the organization. Business cases are our friends as leaders. And so just from a business case perspective, the incremental approach to adding FTEs. And so, of course, we realize that as we pull people from frontline to help support this more administrative work, we have to backfill those roles. And so it was very much, it took about 5 fiscal years for us to really level set and get the backfilling piece that we needed. But again, taking that incremental approach instead of, hey, we need 4 FTEs. And so I think that was a way to make it more palatable. They completely understood a lot of the regulatory things that we were dealing with and at an increased rate. And so, I think it's just justify, take the time as the leader, believe in what your vision is, support the staff, make sure you're highlighting the staff and their skill sets and promoting from within. I think that really goes a very long way. As we know, as pharmacy team members, it's sometimes difficult to translate pharmacy to non-pharmacy individuals, whether they're, someone that we report to or someone that's adjacent to our roles. And so it did take some time, but we felt very, very strongly. And also as the program expanded, we showed the value and the impact of the work that we were doing. And so, increased data reporting, the increased compliance around the audits that we were doing now that we had the people to do the audits. And so showing your work after the fact is always very, very key and a principle that I adopted early on in my career. And so, it helps to have excellent leadership also. They were very receptive. And so having that rapport and that relationship with them was key.
Yeah, that all makes sense. You haven't mentioned it, so I'm assuming not. Did you have any kind of event at the beginning that helped you see, we need these people? Or was it all just your vision and your recognition that we are lacking in this area to be best in community? We need to, for patient safety, spruce this up. Because a lot of people get their resources once they have an event, as you know, right? Sure. Now, all of a sudden.
Sure. Most of it was vision, I will say, but I think that the impetus also was the fact that at the time when we transitioned, our medication safety officer being a nurse and she only works part-time. She was kind of transitioning into retirement. I think being able to account for not having a full-time role, talking amongst other like hospitals and within the health system to say, oh, this role is traditionally a pharmacist role. It is a full-time role, and these are the reasons why. This is the gap between what we currently have and where we want to be. And so kind of taking that, this is what we're not able to do because of the amount of FTEs or productivity that is currently assigned to the workload. And so it wasn't a specific type of sentinel event or anything from a patient safety perspective in particular. It was an accumulation of a lot of things. And again, taking nothing away from the very, very excellent seasoned nurse that had that role,
Sure.
but using it again as a leaping off point to really say, where do we want to be? Let's just not fill a part-time role again, just because it's the easy thing to do.
Sure, that makes sense. All right, Jeri, let's talk about the evolution of your role. I was curious whether you were hired into the role or if you grew into the role. And so Jen kind of answered that, but I'm sure there's a lot more to the story. And as you were doing your residency and stuff, is this an area that you saw yourself in, or you just kind of had that skill set for it and she recognized it? So tell us about how your role has evolved.
Sure. Thank you, Terry. As you mentioned, Jeri, Jen touched base in a lot of the areas where how this came up with. But when I started as a clinical pharmacist, I was a emergency medicine pharmacist as well as a cardiology pharmacist before I transitioned to be the medication safety officer, which soon after this concept came up from, again, our creative director, Jen, with having a managerial position to be working on quality, safety, and regulatory compliance. And my interest developed because when I was a medication safety officer, I was doing was more of like a joint commission preparation, a board of pharmacy preparation was part of it, on top of what I was focusing on the medication safety aspect. So the role of this quality, safety, regulatory compliance within the pharmacy evolved over time significantly. So locally, it began with focusing in compliance, as I mentioned, quality and regulatory oversight, but that has grown proactively to risk management, quality improvement initiatives, as well as interdisciplinary collaboration. So I work very closely with nurses, providers, locally, as well as at the health system level. This division now plays strategic role in terms of standardizing practice, driving system-wide safety protocols, as well as aligning pharmacy operations with broader organizational goals. So as I start diving into it, I became more interested. I was like, oh, why? There's a lot as a pharmacist we can do. We don't necessarily have to be doing staffing or like dispensing or just checking medication. There's a lot that we can do and we can contribute. So definitely the evolution of this particular area reflects the shift from being reactive in compliance to be more a proactive leadership in quality, safety, and regulatory excellence. And that's really, really what I really appreciate and love to do.
Yeah.
In terms of additional FTEs, again, I know Jen did touch base on this as well. Why we started advocating for additional staff is, as you know, the regulation expands, as well as responsibility of my division started expanding. It was obvious that we needed to have additional staff. And again, Jen has this magic in convincing the leadership. I don't know how, but that's her quality. But again, with providing data. Sometimes you just have to present something for the leaders to see. So we were proving over and over again that the reports, the data that we were presenting, helped us to get this additional FTE. And additional personnel definitely allow us to be to have more comprehensive coverage in like high risk areas such as OR area with anesthesiologist audits, a timely response in different incidents that we're having. It helped us in my division to have a deeper engagement in prevention strategy, instead of reacting to errors. We are more preventive preventative, as well as we have drug diversion mitigation strategies. And by using this additional staff members, we were able to accomplish a lot. Some of the areas that we've been focusing on included, we do perform different types of audits targeting controlled substance workflows. We monitor and analyze early detection diversion patterns. All this is required definitely additional resources. In addition, we do optimize surveillance technologies that we have in place. We have staff education and training on diversion prevention. We were also able to focus and collaborate with nurses and physicians in terms of strengthening controls and reporting mechanisms. So those are the areas that we've been working with this additional staff that we have. So
yeah,
I'm very grateful and appreciative of the support that I get from my director as well.
Yeah, for sure. Yeah. And I want to drill down and get some of the things that you guys actually do day to day. Excuse me. But tell me first how your role in quality, safety, and regulatory is pharmacy. I'm assuming there's the quality safety department within the facility as well. How does your role integrate? Do you integrate with them? Do you participate in any of their regular meetings and conversations surrounding survey and all of that kind of stuff? How do you integrate with them?
Yes, definitely.
Yeah. Okay, Jeri, I can start, and then we can kind of talk about you how you and Nicole. So, of course, we do have a quality and safety division who reports to our chief medical officer. A very comprehensive group of highly trained individuals. They have quality patient safety committee. I actually sit on the medical quality sub board of the full board of the hospital. And so from a pharmacy perspective, I mean, we are represented in all things around quality and patient safety from a hospital perspective. So the reporting out, we do annual reports. We report out any type of incidents, either at pharmacy and therapeutics or again at the quality patient safety committee. And so we are very much integrated with their teams. The regulatory team, we have a director on site who is very, very involved. We do environment of care rounds. We do joint commission prep proactively with that team. And so pretty much standard in probably any hospital pharmacy. There is definitely a dotted line with pharmacy, mostly from a director perspective and the medication safety officer and Jeri's role around all of the things that we do from a quality and patient safety perspective that would roll up into regulatory too. Sure. Go ahead, Jeri.
Sure. To add more, I mean, she mentioned most of them, but I'm a liaison pretty much for the Department of Pharmacy as well as the nurses and physicians. So I work closely with the quality and patient safety department in terms of being prepared for either joint commission visit or any types of a state or a federal inspection like CMS. We work together. At the same time, I do present the findings from any of my investigation audits to different committees that we have currently. So we work together hand in hand. And then the patient safety side, as a med safety officer, I work very closely in terms of looking into errors. If there's any kind of patient-related situation that I need to look into, I work closely with that division as well. Actually, as of this morning, we were collaborating on a finding. So we were looking into it together. So I really, really closely work with them. And again, as I said, this is like a liaison kind of position that I have. So that makes it easier to work closely with them.
Okay. So you're the primary for a drug diversion investigation in terms of quality and regulatory. You kind of take the primary lead and then liaison with the larger group if needed.
Our liaison is again Jen, because she's our director. But again, I support her providing all the reports, the data. In between me and her, yes, we are kind of liaison for.
Gotcha. Okay. All right. So Jason, let's get down to day. What do you do? What are the programs that you and the rest of your team do under the direction of Jen and Jeri? In terms of diversion, mitigation, and monitoring?
First of all, Terry, I just want to say thank you for having us on. The day-to-day tasks that we do involves checking Pix's discrepancies, making sure that everything's up to date in our controlled substance safe, making sure that everything is accounted for, receiving meds, expiring meds. That's just a couple of things that, in addition to checking recalled medications, that's all. That's like some of the processes that we do on a day-to-day basically. Yeah.
Basis. I'm gonna stop you right there and clarify something. You said Pix's discrepancies. I think you said
Yes.
Pix's. Pix's discrepancies. Do you just make sure that any discrepancies are being resolved, or are you reviewing resolved discrepancies?
So I am reviewing resolved discrepancies, making sure that everything is resolved appropriately. So, for example, if a nurse miscounts and I double check to make sure that numbers match up, then, for example, they enter in 9 instead of 10, and then they go back in and fix it, enter in 10 instead of 9. Okay, count matches up. Everything's accounted for, no issues.
Okay. Yeah, I think that, it's interesting to me. There are a lot of hospitals that still don't do that. And I don't know if they maybe don't recognize that you can tell the machine anything you want to tell it, right?
Mm-hmm.
Not true with the safe,
Sure.
but the machine's up on the floors, so you could easily be missing something and just have a nurse staff member just change the count and it's missing. So that's why it is crucial that you review every resolved discrepancy, not just, it's one thing if you want to have an initiative to get whoever's resolving it to resolve it accurately, right? Because we all know they just say miscount. It's like, no, that's not really what happened. So that's maybe an initiative. But in terms of diversion, you could actually have things missing. So that's crucial. Okay, so carry on. What else do you do?
So I help out with day-to-day processes in the central area. I double check to make sure that meds are being expired correctly. I run multiple audits, including the weekly nursing inventory, the OR daily report as well. What else do I do? I double check to make sure that that's all I can think of on the top of my head at the moment.
I can help.
There you go. Thank you.
So we have several audits that we perform. We have a daily audits, we have a weekly audits, as well as a monthly audit. So when it comes to the daily, as he mentioned, one of them is a Pixis discrepancy audits that we do on a daily basis. As you mentioned, Terry, it's very, very important. And we're learning now, nurses will do fixed counts, but sometimes the count is off. So that's where we come in and help them. Okay, yeah, you did resolve it by saying wrong count, but then this is missing. What happens? And then that's how we're able to support the nursing team. We also do an override review for nurses in terms of whatever they're overriding from Pixis machine, making sure there is a match in Epic order from a provider. In addition to that, we have to have like either admin record or return record or waste records in Epic. So that's something that we help the nurses. That's a daily one too. Then another thing that we do is we have a compare report, what we call the compare report. That's something that we do in our C2 controlled substance vault. That's done per shift. That's another audit we perform to make sure all the transaction within that shift is reconciled. And then if there's any discrepancy, it's resolved in a timely manner. So we do it 3 times a day, because we have 8-hour shift in our pharmacy.
Okay, and that's your team is doing that. You're not asking the individual. Okay, so I think that's a difference. I've seen it where the tech themselves that ran or before they leave runs the report, but your team is doing it, which helps with compliance because not everybody always does it, right? And then you talked about reviewing overrides. So your team reviews overrides, not the pharmacists. That are okay. All right. So that's a difference as well. Yeah.
Yes. our division is doing this.
Yeah.
When it comes to a weekly ones, we do inventory compliance, as Jason mentioned, for nurses to make sure they're counting their controlled substances on a weekly basis. There is some part of the anesthesia machines where pharmacy staff are counting. We do overview that piece as well. The anesthesia audit, is another one that we do on a daily basis. This is specifically anesthesiologist transactions. That's actually huge. We do review their activities on a daily basis. That's something that we do on every single day. And we work closely with anesthesiologists. If there's any discrepancy, if there's something that's outstanding, we work with them and then help them to resolve it in a timely fashion. And
sorry to interrupt, are you matching anesthesia records with dispenses and that kind of reconciliation?
Yes,
okay.
We check, we reconcile their dispenses, their admin, and their waste. Okay. So we do a full circle of audits for anesthesiologists, which is huge.
Yes.
After actually my division, yes. Jen,
Jeri, can you just real quickly explain how we do those and communicate daily, and how Nicole, as the pharmacist within your division, owns that, and how this is much more of a proactive approach that has grown over the last couple of years?
Oh, sure. So as we mentioned earlier, I have another pharmacist that works under my division. So she's a quality and regulatory compliance coordinator. So what she does on a daily basis is review every transaction, every individual transaction of the anesthesiologist, from pool to administration to waste. If there is anything that does not match, whether it's a true actual missing, or we call it true discrepancy, or if it's like a mischarting, which we call it as a forced discrepancy, we do created an email thread where we're going to be communicated to the individual who was involved with that. And we involve the leadership in that division, anesthesiologist head, to within that email. And we send email every day. If the outstanding issue is not resolved within 48 hours, we follow up and then let them know this is an outstanding issue. Can you get back to us? I can tell you, after this division started doing this, we came a long, long way. So they're very proactive. They're engaging. Sometimes we get a call from them and say, I did this because this happens. This wasn't the case before, but now they're very proactive. We are working very closely with them, and it's working for them as well. In our hospital, they won't be able to close their case unless they resolve a discrepancy. That's something that we came up as well. They can't close their case unless the discrepancy is resolved. So it was a win-win for both sides in that term.
How do you have oversight over a provider that you continuously have to still talk to, right? Because we all know we can say anything we want to make everything reconcile. It's like, shoot, I forgot to do that. I'm diverting, and shoot, I forgot to, record that I did it. Do you keep tracking, trending in some way, and then take it to the next level if needed?
Yeah. So, real quickly, Jeri, I just want to make this point. We actually have an assistant vice president of medical affairs who works directly under our chief medical officer. She was a practicing physician and surgeon here. She has historically excellent relationships with not only PAs, NPs, providers, but obviously the anesthesiologists, because she was a surgeon here. And so she really has been such a champion of all the things that we do in pharmacy. She really serves as that translator from, pharmacy world to, hey, I'll talk to that anesthesiologist, so she is our first point of escalation. If anything falls out of that 48 hours, or for some reason, the anesthesiologist isn't responding, we can punt it to another one to kind of go in and dig for us. And so it's really been the support also from the anesthesia leadership that we've had, not only from our assistant VPMA, but our actual chief of anesthesia, who really has pinpointed a few key practicing anesthesiologists to help with these quality metrics and performance improvement initiatives for pharmacy. So I think some of it is just pure luck, but it's also relationship building.
Yeah.
Making sure that we get ahead of any type of provider changes or transition of leadership in those key high risk areas like anesthesia. So
Mhm.
it's always top of mind. We always kind of have that touch point.
Right. Yeah, that's important. That champion and those relationships to bridge that. Very important. I think there is another, if I recall, you guys also review removals after discharge, right? Yeah. Okay. So I know that's another one.
Jason, I think, yeah. So do you want to speak to that process?
Sure. So I run the report daily. I double check to make sure that everything is accounted for, whether the medication has been wasted, whether it's been transferred to another patient, whether it's been vended and actually given to the patient. If the medication has been pulled and there is no information in the Epic system, like, hey, there's no transfer, there's no waste, there's no given, that's when I submit a hero report, and then my supervisors and Jeri follow up and then talk to the appropriate people to see what the issue happened and how it can be resolved.
Okay, great. Jason, what was your background prior to taking on this role? Did you have anything to do with compliance in your previous role? Did you get additional training? Was it just kind of an interest that you had and they recognized? How did that play out?
So I actually worked here part-time on the weekends as a regular staffing technician, and then the opportunity presented itself. So I said, hey, this looks interesting. It'd be nice to try out. So I interviewed, and they gave me, the opportunity to, work with Jeri, Nicole, and my other partners. So ever since that, they've pushed me to get like more certifications. Like, hey, we need you to help with this. This would be helpful. So I've gotten like the controlled substance certification from PTCB, the hazardous drug management one, medication therapy, patient history as well. So that's kind of things that I've done in order to help me do my job better, basically.
Okay. All right. Excellent. Does your team, I know you have software, diversion software, is your team in charge of the software and monitoring for that? Or do you have somebody else in a central location for doing that? How do you integrate there?
So the software, we are for the pharmacy department, we are kind of in charge for that software, but unfortunately the software that are out there are not fully developed yet. So we're using it to some extent, but not fully. But there's also a health system support that we get where there's a couple of people from the health system who regularly review these reports, and they do some types of audits from the health system. They call it case incidents, as well as they look into unreconciled medication through that system. And it's been helpful, but as I said, because of this software not fully developed, there's a lot of things that are lacking. So currently we're using a local report from a Pyxis and Epic standpoint to do our reviews. But definitely we're looking into another software as a health system. So we're hoping to go live with the more developed one soon, so that we can be using it as intended. But there is a health system reps who are using it right now at this point.
Okay.
That health system group, they're pharmacists and pharmacy technicians, and they're actually helping to serve all of the hospitals in the health system. And so it comes from a generic email account, let's say, and if I notice based on the software that Nurse Betty has a standard deviation of 1.5 or 2 degrees higher than the rest of her peers, they will directly email the manager of that area and say, hey, we're noticing this. They CC Jeri, they CC me, and so it's very communicative. But again, that centralized source is servicing all of the hospitals. So to supplement that, Jeri and her team run local reports as well. We also take cues from Jason and his counterpart as well from the work that they're doing on any given day. So if any report or audit on a daily or weekly basis comes back with any trends or with anything kind of suspicious, that also is a trigger for us to kind of dive a little bit deeper. So as best we can, we have as many bases covered as possible.
Right. Okay. So your team is looking at the software and you've got somebody else that's also supplementing, and then you're doing all of these other things. I'm curious. I think a lot of what you're doing is you're doing it to mitigate, as well as monitor, but also to mitigate and to just make sure from a regulatory compliance safety perspective, you guys are locked up tight, and that it's just great, all of the things that you're doing. Have you found people that you feel might be diverting through any of these? I used to keep a record when I was working at an independent hospital, right? And it's like, well, I may find one because of a Pyxis discrepancy, one because of a billing issue, one because of a removal after discharge. And so you find these onesies, twosies. So you do a lot of work. And, what do you find? Not too much, but you do find, and that's why you do it, right? And then also people know that you're looking, and so that helps to kind of mitigate things. Have you found any one thing, or is it just kind of that combination and very much from a mitigation perspective?
So full disclosure, right after your team's visit, Terry, we dove in even prior to getting the report because we did hear loud and clear from your team that an area of opportunity here, just from hospital leadership perspective, was to make our quick diversion response team a little bit more cohesive. And so, ironically, at the same time, about 2 weeks later, we had an incident that bubbled up. And it was actually reported not through the centralized software piece, but by behavior from a nurse peer.
Oh.
And so the full investigation included, myself, chief nurse, med safety officer, security and public safety, HR. And so and risk management, of course. And so, it took, like I said, about 3 weeks. But because it was behavior driven, we had some data to support, and we pulled in corporate security as well, who focuses only on kind of threading that needle and making those final recommendations for the health system. And so we really were able to use this particular piece to jumpstart our diversion response team cohesion even sooner than we thought. And so we developed a process map. We have full buy-in from our executive leadership. We revamped our local drug diversion team to be our controlled substance management committee, and we expanded all of the membership. We had our first meeting about 4 weeks after your team was here. And so we really very quickly turned around a lot of these things where we felt were high points of risk. And so I will say collectively in the years that I have been here, there have not been many instances. That being said, I do feel as though at different points in time, we probably, because our diversion response team was left more at the manager level versus the executive level, it had a little bit of bias involved.
Sure.
And so one of the first things that we did was pull the unit-based nurse manager out of anything after the initial investigation. And so in retrospect, the CNO and I have had multiple conversations. We heard loud and clear from your team, and thankfully so. And taking that bias out of there really just drove this process for this particular incident. Without divulging too much, it was behavior driven. It was not as conclusive as we would like it to be, based off of the data and based off of, your analysis test, et cetera. However, the recommendation was that, this person is diverting. Yes. And so, we actually were very thankful that we had this case at the same time we were trying to, because sometimes, you sink or swim. Sometimes you have to
Right.
be in it to really fix it
Right.
the right way. So,
Yeah. Yeah. And it was
yes,
fresh. I mean,
it's
we
very
had all
fresh.
the conversations.
Yeah.
Yeah. Yeah. I'm
Yes.
curious too. I'm curious too if the peer reporting is so important. And that
Yes.
is why there's such a focus on culture. I mean, what is the culture? Do you feel that your employer is punitive? Are they helpful? Do they want to get people in recovery? Because peers are going to be more likely to report if they think that their colleague is going to get help.
Yes.
And there's not going to be all this retaliation and what have you. So I'm curious if any of that willingness of that peer had anything to do with the fact that we had all those conversations with staff members when we were there.
Yes.
Yeah.
So I will say, again, one of the things that were fresh on our minds after your visit was very much, not so much of what is our quick response to any type of potential diversion, but what does also this diversion prevention and response team, what are they responsible for kind of like longitudinally, long term? How do we make sure that all of the things available to us as practitioners through the health system, through HR, they're there, but are they communicated well to the staff?
Sure.
So as some of your team members spend some time with HR and public safety and occupational health, and those policies are there around. What does this look like? What are some behaviors to look for? But in the results of the survey that were sent out, and then the survey results that came back from, nursing team, pharmacy, and leadership, it was pretty clear that there's a large portion of practicing staff, especially bedside nursing, where they don't know off the top of their head, or they couldn't name, 2 or 3 things where they would recognize if a peer seemed a little off, or what are the behaviors to look for. So that came through also loud and clear. And part of the work of the diversion response team not only is to gather quickly in real time for any potential diversion case, but also how do we collectively, because it is a very interdisciplinary group, how do we collectively keep that message top of mind? How do we create space and create just a little bit of a deeper culture around that piece of it? How are you supported as someone who potentially is reporting someone, that you consider a very close peer? And then also for staff who have a problem, do they really recognize or know all of the availability of programs within the health system and locally, the support that they do have in case they do have a problem, and how we would support them in getting help? So that is definitely a part of the plan as we go forward with our action plan. How do we support all of this a little bit more in real time? And I think from a leadership perspective, when you were here, it was clear that our executive leadership is all in. They said we have a great culture here, but I think that there is some apprehension around this particular piece because it is such a sensitive topic.
Yeah. Well, you got to disseminate the information, but it's also odd to talk about that, right? It's like, well, why are we, so it's kind of that it happens. We can't just ignore it, but we don't really want to necessarily talk about it because we hope it's not happening. But at the same time, you need to disseminate the information. So that's great. Okay. So I was going to ask you if there are any initiatives that you're working on. So you're a diversion response team working on that, and you've now had some practice on that, disseminating the information so that what you already have in place is known to your staff should they need it. Any other initiatives that you're working on?
Well, taking into account, the report that we received back from you and your team, and also some of the things that we collectively here have been kind of wanting to put a little bit more structure around. We're working on security cameras. Just the other day, Jeri did a walkthrough with our vendor and our director of public safety, went to every single med room, did a walkthrough with pharmacy, the IV suite. So we're definitely going to reconcile that. Already have talked about a lot of these things, because at the end of the day, things cost money. And my VP is supportive of all the work that we're doing. We do have some opportunities within pharmacy to close the loop on a couple documentation things, record keeping. We also have assigned some of those critical areas with champions.
Fantastic.
Right. So it was very clear in our report that ED, critical care areas, and peri-op areas are some areas where we need to tighten up a few things. And so in our first controlled substance management newly formed committee with a broader audience, we talked about the action plan. We assigned team members. Of course, I'll be the liaison, with them to help them shepherd the things through that they need as well. It's some things are low hanging fruit. We had one finding where it was, hey, it looks like, in your peri-op areas, the EVS staff are kind of walking around in some open spaces that there's a medication left out. Can you validate that they understand their role in terms of reporting what they see or whatever? And so very quickly, I worked with EVS leadership and they confirmed that it's part of their huddles, it's part of their job descriptions, it's part of these things. And so, we love our action plans. We're really good at sifting out low hanging fruit. And so, again, there's a lot of opportunity here for us to tighten up the things that we're already doing well, but could do a little bit better. So we do have our second meeting next week, and we're taking a divide and conquer approach, knowing nothing's going to happen overnight, of course. But with this team in place and with the leadership team external to pharmacy, they truly understand, the criticality of controlled substances. I think bringing your team in really kind of helped put some muscle around, hearing it from someone other than Jen and Jeri around the things that we have to do. And so, I just think that it's the timing and the stars have aligned, and we have full engagement, full support, and we're ready to get going.
That's great. And I love that you've assigned champions. I'm very much a champion for champions. I think that is so important. Well, you guys are doing great work. Like I said at the beginning of this, you are doing so many of the things. You have so many of the pieces in place that a robust diversion program needs to have, and you're doing it. And that's fantastic. And we can all always improve all the time, constant state of improvement. So I think that you guys are doing a great job. Keep it up. And I want to thank you for your time today. Any last things that any of you want to share?
I just want to share real quickly. I am so grateful and thankful for your engagement and your team's engagement. I'm also very thankful and appreciative of Jeri, Jason, and the other two members of the Quality, Safety, and Regulatory Division of the pharmacy here. The work they do is just so detailed. High risk medication, classes, and just the continuous state of readiness, the continuous culture around being proactive. I mean, when you align skill sets and drive and passion with the correct roles, the results speak for themselves. And so I'm just so appreciative of what we already do really well.
Jeri, did you have something you wanted to say?
Yes. Again, thank you for this opportunity. Jen said it all, but I just wanted to highlight one thing for the audience. We usually don't, when we do look at diversion, we don't go by, okay, they didn't meet the threshold, or we're not going to say, oh, this is not a high quantity. We look for trends, even if it's one or like half, whatever that is, we usually focus on trends. That's how we're able to get to it early on. That's what we do, because most of the audits that we do is on a daily basis, that little things can add up. So when we see a trend, we usually escalate it to the leaders. We have great leaders on the unit. They take that and then they focus and start talking to the staff members, and then they started observing those kind of behavior. So it's very, very important to focus on that little things, not necessarily the high quantity, or it's not like, oh, they did this much missing meds. We do look at trends. So that's very important. I just want to share that.
Yeah, that's an important point. I think many people use their software in particular to just find every single, which is great. but that's not going to help you find diversion, right? Poor practice and maybe diversion is in there, but you've got to pull back and you've got to kind of look for those trends. So very good point. And Jen, to your point, yes, you have fabulous people in place. It's also, I think, a testament to your leadership. I think that I'm sure you keep them on their toes. I can just tell, because you are the way you are and you're very driven. But I think that they're very fortunate to have a director like you in place. I can tell they really respect you and the work that you do. So thank you all for taking your time. I know you're very busy and doing a lot of stuff, and I really do appreciate you sharing with the listeners all of the things that you do. And I'm sure there are people out there right now that are very jealous.
Thanks for having us, Terry. It was good to see you again.
Absolutely.
Thank you.
Thank you, guys.
Thanks.
Bye. Have a good day.
You too. Bye-bye.